Good morning, good afternoon, and good evening to all my friends and colleagues around the world. A very happy Teachers' Day to all of you from the Global Summit. That was on 5th of September, which is celebrated in India. And it's indeed a pleasure and honor for us today to have one of the teachers with us, Dr. Sanjeev Bhanderi, all the way from London, the president of the British Endodontic Society. Thank you so much, sir, for joining us for the Podina session today.
Thank you very much, Dr. Prasad, for
Yeah.
inviting me here.
Thank you so much, sir. It's indeed a pleasure and honor for us to have such a great academician and a clinician with us, and that too, especially next to the Teachers' Day. And I think, and that too with the topic, which is, I think, very important as a clinician for all of us, the resto-endo interface. I feel that we mostly work on the endodontic part and we try to not put able to the more focus on the restorative part. And I think today, sir will going to share his thoughts, his experience with us that how a rest-to-ender interface will take to the new levels and how we can actually achieve better success in the coming years. Before we go ahead with the Podina session with sir, I would like to share some credentials with you all. Dr. Sanjeev Bhanderi is qualified in 1993 from Guy's Hospital, University of London. In 1997, Sanjeev completed his postgraduate training in endodontology at the University of Manchester Dental Hospital and has been a GDC registered specialist in endodontics since 2000. He has he has since worked exclusively in the private specialist endodontic practices in Manchester, Liverpool, and London. Over the period, Dr. Sanjeev Bhanderi has been committed to teaching and is well-known lecturer in UK and internationally. Course leader from 2009 to 2012 for MSc Endodontology at the UCLan Pristine, UK. Visiting lecturer for the M. Dent in Endodontology, University of Manchester, UK. Currently working as a senior lecturer at the University of Liverpool Dental School, UK for the DDSC Endodontic Specialist Training Program. He wrote and led the endodontic modules for the Royal College of England FGDP Diploma in Restorative Dentistry up to 2018. Numerous CE courses, conventions for general dentists throughout UK, and has lectured internationally on his specialty in the Middle East, India, Southeast Asia, and Europe. In 2020, Dr. Sanjeev is currently the president of the British Endodontic Society, and he is an active specialist member for the American Association of Endodontics and has a particular interest in endodontic microsurgery. He also works by the legal instructions as a certified medico-legal witness at the University of Cardiff Law School. In 2009, Sanjeev opened his new state-of-art specialist practice in teaching faculty in Manchester, where he also runs hands-on live clinical demos and courses for visiting practitioner and postgraduate students. Sir, it's indeed a pleasure and honor for us to sharing your valuable time on this Sunday with us on the topic, what is the need of the hour, as I always say, the resto-endo interface.
Thank
So I
you.
would like to know that how is your experience, to be frank, before you start your podcast, like after this COVID-19, what do you think the change in dentistry will going to happen?
Well, I think it's going to change. We spoke earlier about teaching. The universities in the UK, the BDS course, the undergraduate course, is going to change completely. Clinics are going to change. We used to have open clinics. There's going to be less patient contact, which is a shame. I think it's the emphasis for clinical teaching is probably going to go on to postgraduate level in the next 3 or 4 years, I think, which is a shame because dentistry is a skill. There's the academic side of it, but at the end of the day, patients have to be students have to learn how to see patients, treat them, diagnose. So that's something. It's going to change the emphasis, and it's going to, I think, elongate the teaching beyond the undergraduate degree. There'll be more emphasis on postgrad training. So that's how it is in the UK. In terms of practice, I mean, we've been open. We were closed for 3 months from the end of March. We reopened on the 8th of June. So most private practices open pretty much straight away, but in the UK we have two different systems. We have the what's called the National Health Service, which is the government funded system, and private practice. So private practice is pretty much open straight away in June. The government national health, they haven't quite fully opened, so it's an interesting time. For us in private practice, it hasn't affected me really since we've opened. We see less patients because we're required to do a lot more cross-infection control, as is understandable. But we have to do what's called a fallow time. So in between each procedure, AGP procedure, we've got to leave 60 minutes minimum. We can mitigate that with rubber dam and high volume aspiration, but there's a lot of uncertainties. There's no evidence for any of this, but we have to do it because the government have told us to do it. So we see maybe 20% less patients in endo. So endodontics, we get away with it. It's the restorative and general practice. Those guys are, you know, it's hurt them a lot because they can't see the number of patients. So
Absolutely. I think, sir, you must be seeing a very drastic change since 1993 till 2020. It's like, I think it's a long journey which you have actually traveled in a different zone, I think, from the basics to the advanced level. And we would like to know your experience, sir. How exactly, share your experience with all the people around the world so that we can learn from your expertise.
Well, 93, this is just before rotary endodontics became really fashionable. So I was taught the old-fashioned hand techniques, circumferential filing, Rowan technique, or hand files, and no rotaries at all. And then when I came out of my master's program in '97, I finished the master's program. That's when rotary endodontics came into play. I bought my own endodontic equipment because it was so unique. No one had heard of it. And the practice I used to work for, in most general practitioners they couldn't afford it, to be honest. So I bought my own unit, and that got me interested into endo. And I left general practice. I've been doing exclusively endodontic referral practice now since '97, pretty much. I've not done a crown prep for that long, or denture, so I don't miss it at all. But it has. The principles are still the same. When I'm doing my postgraduate teaching, even undergraduate teaching, the principles have not changed. It's just how we do them. The instruments are better. They're easier to use. They're more predictable. So the procedure, endodontics, it's more enjoyable, I think. And in the UK, we certainly see this. General dentists are really into endo, whereas before, when I was came out of graduate school, everyone used to think I'm a bit mad doing endo. Do you like endo? How can you like doing endo? But nowadays, it's really popular. There's so many hands-on courses, as you've seen on your training. It's big. Internationally, endo is really good, really popular, which is good. Because endodontics in restorative dentistry has always been what we call the poor sister. Everyone looks down on endo and they try and avoid it, and they stick to the glamorous, cosmetic stuff and crown and bridge work and the implants. But endo's coming back. It's really resurgence in Europe.
I do believe in the same, because I think the endodontics is one of the integral part of the dentistry. That is, I feel, is very important, and especially when we are having a lot of things happening around the world. And endodontics is one thing which is, I think, it's a backbone. And as you shared, sir, that with the increase in the skills, knowledge, and I think with the equipment, I think what we have changed with time is the thinking, that we have start thinking ahead of time, so that we can reach to the maximum and to the best possible with the terms of equipments and all materials. And I think in terms of the evidence-based dentistry, that is more important, which is coming up. And sir, I think that you have been on the microsurgical level, and magnification is one thing which I love always be on as an endodontist. When we talk, it's like the magnification is changing the world of the I think the not only endodontics, I think it is applicable in all the fields of dentistry. So how do you take it as the future for our the young leaders who are coming up? What is your message to them for that?
This is a really good time for endodontics, for young dentists coming through, because in our day, you were the odd one out when you liked endo, and it wasn't taught particularly very well. But nowadays, there's some more. The teachers are there. There's more general dentists doing endo. The youngsters enjoy it a lot more. Magnification is a basic in their undergraduate courses in the UK. All the students have to buy loops as a start. So it's great in restorative, as you said. Restorative dentistry, you need to have magnification now. I think for diagnosis, for treatment, but endo, it comes into its own. I mean, you can't see what you're doing really. Once you had that, and microscope all postgraduate courses now. It's mandatory to teach microscopic endodontics. Surgery is one of my baby subjects, which I love, and I trained in America. I went to America to do my surgical training, so it's an exciting time for young dentists to get into endo, and we're trying to save teeth now. There's plenty of teeth. There's big demand. Patients don't want to have their teeth out. I mean, implants are around, but in the UK, certainly, I think the pendulum's gone back. It was implants maybe 10 years ago. Now it's come back towards endo because implants don't always work. There's problems with implants. So endo is really important. And one of the topics today, part of this discussion is, at the end, we'll discuss, should we take fractured teeth out or not? That's
Yes. I think that's the need of the hour, because I think a lot of teeth are being extracted nowadays just because the people are not able to actually have some protocols, or probably I think it is because some interfaces, let's take it this way, is not clear between a resto and an endo. And I think with the help of magnification and with your able guidance and all these expertise what you have, we will able to learn together today that what is the exact interface to avoid a tooth fracture. And I think that's the one we all are looking for. So I kindly request you now to please take over the session and enlighten all of us with your expertise and with your knowledge. Thank you so much, sir. You can take it.
Thank you very much, Dr. Prashant.
Yeah.
Before I start, I'd just like to apologize in advance. I've had a cold for the last 3-4 days. It's definitely not COVID. I got tested, but a bit of a sniffle, so I might have a sip of water every now and then. So I apologize if I sound a little bit, throat sounds a bit dry. Okay. Great. Can you see the screen? How's that? Everyone can see the screen?
Yes, sir, we can see.
Perfect. Good. Thank you, Dr. Prashant, for inviting me to speak. I thought I'd choose a topic that's not directly endodontic as such. I think everyone's been endoed out over the last 4, 5, 6 months with all these endodontic seminars and irrigation and rotary and this and that. So this is something different, and I think is really important because although I do endodontics, and that's what I see in my private practice by referral, a lot of the cases that I see have some involvement of or have been affected by fractures in some way. And it's a difficult dilemma sometimes of how to deal with these. Do we automatically take teeth out if they've got fractures? And diagnosis also is quite difficult as well. And this is where magnification comes into play, being able to identify the fracture, first of all, and then if there is a fracture, trying to ascertain how deep the crack goes within the tooth. And then we'll also talk about the prognosis, because it's not automatic that these teeth have to be lost just because they have got a fracture. There are different things that we can do, mitigating factors, restorative procedures that we can do to try and save these teeth or at least prolong their life. So that's what I'm going to talk about today. Just a brief bit about myself. Dr. Prasad given me a very nice introduction. Thank you. So I actually initially qualified in London at Guy's Hospital. Some of you who've been to London, central London, may recognise this. This tall tower is called the Shard, and it's the tallest building in the UK. I think it may be the tallest building in Europe. I'm not sure, but it's a hotel, a Shangri-La hotel. But right next to it, there's this building. This is Guy's Hospital Tower, where I qualified, and it's got a very big endodontic unit, some quite well-known endodontic teachers and academics there. So I got my undergraduate foundation training with Professor Tom Pipford, who's one of the founders of the NTA. So I had a really good endodontic background right from the beginning. And then soon after that, I moved up northwest, which is about 200 miles north of London, to Manchester. And I've been teaching, as Dr. Prasad mentioned, teaching in Manchester and Liverpool. And at the moment, I'm a senior lecturer on the specialist doctorate program in Liverpool. So there's only 3 dental schools that have postgraduate endodontic training in the UK. One is Guy's, the other one is the Eastman, which you would have heard of, and Liverpool's the third one. So there's not many places that train specialist endodontists in the UK. So I'm privileged to be part of that program. It's a 3-year full-time program. So we start our new academic year after COVID in the next couple of weeks. So it'll be interesting to see how we go. But essentially, I teach in Liverpool. And then I have a private practice, which I'm in at the moment in Manchester, which is not too far away. So I've had this practice for 10 years and just treat patients by referral, just for endodontic needs. So this is where I live majority of my time. So just to go on to the endodontic aspect. So the pulp, we know all the different causes of pulpal disease, caries, trauma, even the procedures that we perform, or not ourselves, if you're general dentist, all the restorative procedures, and they do have an effect on the pulp, and we need to bear that in mind, or at least remind our general dental colleagues who refer to us that every procedure that they perform, if it breaches the enamel, will have an effect on the pulp. Most of the time we get away with it, but sometimes the pulp is affected, if not immediately, over a period of years, and that's something we need to bear in mind. Also, we're getting an increasing number of patients, particularly young patients, who are having these masticatory accidents, and they'll bite on something hard suddenly, either knowingly or unknowingly, and they may cause a localized damage to the tooth or fracture, and the classic acute pain after they've bitten on something hard, a seed or a nut or something like that. And then this is the topic I'm going to concentrate on today: how this sudden impact, rather than trauma, but masticatory impact, can affect these teeth, and what do we do about them? So that's an increasingly common cause of pulpal disease, both reversible and irreversible, and quite difficult to manage. Also, not to forget, another problem we're finding in the UK certainly is the parafunction and long-term grinding habits, particularly in younger patients, young professionals, due to stress levels or socioeconomic reasons. So you have this prolonged occlusal forces applied to multiple teeth, and they can cause micro cracks, they can cause crazing in the short term. In the long term, you get chipping of teeth, and these sometimes will eventually end up having pulpal problems, and we need to be able to identify this, hopefully at an early stage, and protect these teeth before they do become endodontically involved. And this is the remit of the general dentist, or those dentists that see patients regularly. But this is another problem we do get that cause tooth fracture, multiple tooth fractures often. Now, the evidence, we try and do everything evidence-based, and a lot of in terms of tooth fractures, most of the evidence and research has been done more in the restorative field in terms of occlusion. Endodontics, as we'll talk about later on in the presentation, we're now understanding a bit more about the pulpal implication, the pulpal effects of tooth fractures. But up to now, a lot of the research has been based on all these various fields: occlusion analysis, muscular, TMD, migration, orthodontics. We haven't got time to talk about all of these, but just very briefly, just to remind you, we are all general restorative dentists, and we do need to remember the occlusion. And when we're doing our restorations, we must remember the basic principles of occlusion. This particularly if we're doing rehabilitation, if we're doing reorganization of multiple teeth or lost teeth, whether it's removable, fixed, removable prosthodontics. We have this ideal tooth relationship we're trying to recreate or return to, and all these different aspects, canine molar contact, angulation, rotation of teeth. We all try and, when we're doing our restorations, trying to restore patient's dentition to this level. So we've got, this is the ideal occlusion, where you've got the mesiobuccal cusp of the upper six, which it interdigitates with the mid-buccal groove of the lower six, and obviously the canine to canine contact. The upper canine tip is always slightly distal, and this is the ideal kind of occlusion and canine molar contact we try and achieve, particularly if we're doing multiple restorations. Okay, we must also remember contact points, and obviously contact points are important in terms of plaque control and perio and gingival health, but also they do have an effect on the integrity of the tooth, and contact points ideally should be on the coronal third rather than higher up towards the embrasure space, and that has a bracing element, because there has been research from the Eastman. The teeth that have lost, particularly root-filled teeth that are not are either standalone teeth that don't have teeth either side, adjacent teeth, the prognosis for those teeth is poorer if a tooth is not embraced by teeth either side, mesial or distally. But also when you lose teeth, you start getting tilting, you start getting rotation of teeth, you start getting contacts between the occlusal cusps and occlusal surfaces that weren't there before. Teeth are arranged and designed, and through evolution, they have a certain shape, they have a certain anatomy, certain root anatomy, certain angulation, certain tilting, and it's all done because of the occlusal surfaces and occlusal forces that are applied. But when teeth are lost, this can change, and you can start inducing contacts which are not natural. And this is when things start going wrong. This is when teeth start chipping, cusps start breaking, fractures develop, and either because of teeth taken out or because of restorative reasons. If we start introducing restorations that are too high, or other appliances that affect adversely the occlusion. So we need to bear in mind all these things in our restorative dentistry, because they do sometimes have a long-term impact on the endodontic health or pulpal health of the tooth. Okay. The definition of occlusal trauma. So basically, if we when we do our restorations, we mustn't induce occlusal trauma. The definition of this is anything that alters a natural occlusal forces beyond the norm or outside the norm. And it could be a simple high restorations, it could be removable appliances or fixed appliances, even bridge work or implant supported teeth, where there are opposing teeth and we introduce a contact that wasn't there before, and that will eventually have an effect on the natural dentition, whether it's a fracture, whether it's orthodontic movement. We need to bear this in mind. Orthodontics is an interesting one, because certainly in the UK, and I'm not sure how it is around where you are, that we're doing a lot of what's called fast orthodontics, rapid orthodontics, not necessarily the conventional fixed approach. And teeth are being moved for cosmetic reasons, for aesthetic reasons, into positions that they're not naturally designed to be in, and then they're retained. And this in itself can cause occlusal contacts which weren't there, and occlusal forces. So there's something to bear in mind if you're doing orthodontic treatment or rapid orthodontic treatment. You need to plan or have an idea that when the treatment's finished, where these teeth are going to end up, and will that have an effect on the opposing teeth and on that tooth itself. So orthodontics is an interesting one. It's getting more of an issue with chipping teeth and even resorption. We're seeing resorption, long-term resorption, possibly due to occlusal forces which weren't there before. In terms of endodontics symptoms, obviously once the tooth is restored, and if, for example, there's a high contact, the patients will often come in with localized tenderness, and also, interestingly, they have thermal hypersensitivity in a tooth that's in hyperocclusion. I'm not sure how the mechanism of this works, but it's a localized pulpitis. But this is very easy to solve. Identify the high spot with articulating paper, for example, and relieve that. So that, in most cases, post-restorative localized pain due to hyperocclusion is very easy to identify and resolve. What about post-operative pain due to endodontics, due to root canal treatment? Sometimes we do root canal treatment, and there is post-operative pain after this, simply because of the procedure, due to irritation apically. And often happens in teeth that have an irreversible pulpitis, completing those in one visit. Sometimes the patients get a residual percussive tenderness, particularly lateral percussion, and it is often useful for in these cases to maybe relieve the occlusion, over-relieve the occlusion, make sure there's no interferences or high spots on the temporary dressings or the restorations. So that's dealing with post-operative pain immediately after endodontic treatment. So we must make sure the tooth isn't left high, because the patients will return very quickly with tenderness. What about the effect on the structure of a tooth, whether it's primary occlusal trauma because of restorations or orthodontic movement or anything like that? And also, how does it affect the pulp? This is where we're going to discuss a little bit more detail. It starts off with our history examinations. For a patient that comes in with tenderness, localized tenderness in our tooth, particularly on biting or chewing, we do need to go back to basics and get a good history. Now, social history is quite important. We mentioned before parafunction, and certainly in the UK, we're finding a lot of younger patients, professionals, they have clenching habits, parafunction habits. So social history is quite relevant here. So to ask the patients, what their profession is, and their work patterns, or even if there's any issues at home, personal issues, and any causes of stress can cause parafunction, and that may be a potential cause for occlusal trauma or generalized toothache. So that's something to bear in mind. If dental history is also important, recent dental history. If there are new patients to you, ask them if they've had any dental treatment recently. because if they've had treatment, a filling, replacement, or a crown, and that particular tooth is tender, that might be an obvious reason. There could be an occlusal high spot on that. So these two questions are quite important, as well as the pain history. And then we're looking at the special tests. This is all kind of basic bread and butter endodontic special tests. So we talk about percussion. Percussion is a special test. It tests the inflammatory status of the periodontal supporting mechanism. It doesn't tell us anything about the pulpal status, but it'll give us an indication that there's something wrong with the supporting structures. Now, there could be many reasons why a tooth is percussively tender. It could be pulpal disease or a periapical disease, but it can equally be something to do with occlusion or occlusal trauma, and mobility as well. As I mentioned later on, if there has been any sudden changes in the occlusal context of a particular tooth, you will get an increase in mobility because the periodontal mechanism is trying to adapt or compensate. So fremitus, so biting and patients who are clenching together or snapping together, you'll feel movements or visibly see movements on those teeth that have where the occlusion has changed. We'll talk about pulp vitality in a second, but pulp vitality is important because that will determine whether or not you intervene endodontically. Okay, it's as simple as that. And radiographs are special tests. Radiographs, and particularly CBCT. This is more relevant, of course, in teeth that are non-vital. If you have to start doing endodontic treatment in teeth that are irreversibly or damaged or apically involved, and this is beyond the remit of the talk today, but the radiographs and CBCT give so much information in terms of how you're going to access the tooth, how you're going to identify anatomy, and also periapical disease, of course. But in the context of tooth fracture, what hasn't been considered is the using CBCT for diagnosing. Now, I think it's very difficult to identify a hairline fracture on a CBCT, and the majority of CBCT machines at the moment haven't got the resolution in terms of the voxel size to be able to discern a hairline fracture. If you can see a fracture on a CBCT, it's usually visible clinically as well. For example, in horizontal root fractures in trauma, they are very useful for that because you can't see the horizontal fracture. Usually it's subcervical. But if you can see a fracture coronally on a CBCT, it's probably visible clinically as well. What is interesting, and some of the research by people like Dr. Mo Fayed in Illinois, they're looking at indirect effects of fractures and the result of pathology in the periodontal ligament adjacent to the fracture. So you start seeing subtle changes in periodontal architecture, loss of bone adjacent, particularly interproximally between teeth and behind teeth, distal and mesial to teeth. And those subtle changes are very useful to see in a CBCT, which are not apparent. So CBCT is getting more increasingly used, but not in terms of fracture identification itself, in terms of how it affects a periodontal health. And we'll talk about transillumination in a second. So in terms of the clinical examination, magnification, as we spoke about earlier with Dr. Prashant, it is really important in terms of your general checking of the tooth structure, picking up hairline fractures in teeth. And we'll talk about different types of fractures because not all fractures in teeth are significant. So magnification is the first step. You need to be able to see a crack. If you can't see the crack, there's no way of diagnosing a problem. Dye stain is useful sometimes, particularly into fractures that may penetrate deeper into the tooth structure, or hairline fractures which aren't very clear. So using something like methylene blue or some sort of plaque disclosing solution, this will penetrate into the crack, and it can just highlight and confirm the presence of the crack and also how deeply it penetrates. And this could determine whether or not or how you treat the tooth, and we'll talk about that later on. So dye stain is sometimes useful when you're, for example, doing an access cavity and you're tracing the crack into the tooth, into the pulp chamber, and maybe even down a root. So that's quite useful. Periodontal check is also important. Don't forget, even though it may be an endodontic situation or a toothache, do a quick periodontal check around the tooth. And I always do on a tooth that needs endodontic treatment, just do a 6-point pocket chart, 3 points buccally, 3 points palatally. And if you see an isolated pocket, this particular case, this is a post-crowned upper 5, upper second premolar, and there's an isolated pocket. And in fact, you can see under the magnification, there is a fracture in the mid buccal. And so classically, if you have an isolated pocket in an otherwise periodontally healthy patient, that is not a good sign. That's often a sign that there is a vertical fracture. And I'll talk about that later on. And the prognosis for these obviously is quite poor. So periodontal examination, a very quick check around that one tooth is very important, and to note that on the records. Looking at the restorations, if you start seeing hairline fractures in particularly mesodistal fractures in restorations, extensive fillings, that is suspicious because that crack could well penetrate into the tooth itself. And then what you've then got to do is remove the restoration. This particular case is a root fill tooth where the restoration fractured, and we remove the restoration, the filling, and the fracture penetrates right through the center of the tooth. So this tooth clearly has a very poor prognosis, and it has to be taken out. But this is a bit more difficult to deal with. There's a fracture there, and it goes just maybe into the radicular or the coronal third, and then what tends to happen is here you start getting biofilm accumulation along the fracture, and you get the associated periodontal pocket, which sometimes we can see is what's called the classic J-shaped lesion, but it's not always. The J-shaped lesions don't always mean that there is a fracture there. So we have to be a little bit careful when you see radiographs, for example, on Facebook saying with a big J-shaped lesion merging with the apical tissues down here. It doesn't always mean that there is a vertical fracture. You've actually got to investigate, access the tooth, and visualize the fracture. Can't just assume that from the radiograph. But if there is a fracture, you will get biofilm accumulation, and you'll get the associated pocket along that side. So that's something you need to bear in mind. In terms of classification, this is the classification that I'm familiar with and I use is the AE and the Rivera-Walton classification. I've broken it down into Craze Lines, cracked cusps, and we'll go through each of these categories and how to identify them. What do we do? How do we deal with them? So first of all, Craze Lines. These are essentially just simply enamel fractures. They don't breach into the dentine, often associated with age, kind of general wear and tear in older dentitions. And you'll see these, and these aren't really an issue unless there are symptoms. So these are kind of Craze Lines. You'll see I've got them as well on my lower teeth, and particularly people who have got a parafunctional habit, they're grinders. You will see Craze Lines more often in these teeth. Okay. How do we distinguish that from a genuine fracture? And what I mean by fracture, the definition of tooth fracture is when the fracture penetrates into the dentine. So it breaches the enamel dentine junction. So it goes through the enamel into the dentine. And this is a little more tricky because clinically they could look the same. So one useful diagnostic tool is transillumination. So if you have a Craze line which is purely just within the enamel, the light will penetrate on the, if you try to illuminate behind the tooth on the platal lingual side, it'll go through the entire tooth structure because there's no breach at all. So you'll see the fracture, but you also see light going right through the enamel and dentine structure. Unlike a fracture in the dentine where you will get diffraction of the light at the fracture line and the tooth structure beyond the fracture is dark. So this is a classic sign, diagnostic sign of a fracture penetrating into dentine. So transillumination is very, very useful for this. And if you see the light stopping somewhere within the structure of the tooth, then that's not a good sign. That is a deeper fracture. Then you have to then determine how deep the fracture goes. Okay, so transillumination is quite useful. Cracked tooth or cracked cusp syndrome. This is a huge topic in itself, but essentially, just to summarize, a useful diagnostic tool here is that all the patients will often come in with classic symptoms of pain on release. So they'll bite on a particular part of a tooth. They can pinpoint which tooth it is, but they'll often say it's not when they bite down, it's when they release pressure, when they open up after biting down on the tooth. And that's simply due to the hydrodynamic theory or the mechanism of pain of dental tubular fluid movement. So when the patient bites down onto that cusp that's flexing, just micro flexure, that opens up the crack a fraction, but it's when they release that the cusp pings back into position, and that causes compression and fluid movement, dentinal fluid movement back into the pulp, and that's when they trigger the pain. So it's on release, and the cracked tooth syndrome, that's a classic sign. And if you can apply something like a tooth sleuth, which is a device that you can rest on each particular cusp, and you can pinpoint which cusp is causing the problem, that's a very useful tool also to identify. The question then is, what do you do about it? That's a difficult dilemma. Do you remove the cusp? Do you flatten the cusp? Do you protect it? We'll talk about that later on, depending on the pulpal symptoms. So in terms of cusp fracture, so the cusp could stay in place where you'll get the cracked tooth syndrome, but equally it may present as the complete loss of the cusp. And if it's within the dentine and the tooth is vital, then it's a case of just restoring the tooth. But this is where you do need to check the pulpal status and for symptoms, because if there are any signs of endodontic disease, then you have to deal with that after you determine how deep the crack goes. In this particular case, this premolar here, this looks pretty restorable. There's no exposure, and we've got really nice dentin bonded ceramic materials that can restore this pretty conservatively without the need for full coverage restoration. So this is a straightforward restorative procedure to save this tooth without endodontic treatment. But what about this case where the cusp fractures obliquely, subgingivally? We've all seen this. Always the lingual cusp on the lower molar. This is difficult to deal with, and there's an exposure. So what we need to do here is we need to try and get some hemostasis. The rest of the tooth is reasonably intact, so there's enough ferrule, there's enough tooth structure to hopefully bond onto and rebuild. So we just need to deal with the level of the fracture here. So in these cases, what we try and do is we do some gingivectomy, get some hemostasis, we try and re-establish a margin, build a provisional core with a resin modified glass enema, and then do the conventional access cavity. So relatively straightforward endodontic procedure, and then restore the access cavity and prepare it for a partial onlay restoration rather than a full coverage crown. Again, we've got some very nice ceramic materials which will bond very well with conservative preparations. But these can be challenging when you've got a cusp fracture which is subgingival. It can be difficult to deal with those. What about these situations where you've got a fracture and typically it's on the distal aspect of, for example, a lower 6 or a lower 7? It's causing symptoms. The patient has got some symptoms varying from reversible to irreversible. Do we intervene with these, or do we just monitor those? We'll talk about that later on. But we're getting a lot of these, particularly in parafunction patients that grind their teeth, and younger patients where you've got this distal fracture with or without symptoms, or you might find on a routine examination. There are many causes for these kind of fractures in relatively unrestored teeth, as well as caries. You've got maybe an opposing restoration, a tooth that's been restored, the upper 7 or 6 have been restored. You've got parafunction, as I mentioned before. It could be a masticatory accident. The patient could have bitten something suddenly and has developed this fracture. Could be impact trauma, thermocycling. If there is a restoration within the tooth, and over a period of years through thermocycling, you get expansion and contraction. That in itself, expansion could cause cracking eventually. Dentine pins we try and avoid, because dentine pins cause concentrations of stress which may initiate fractures within deeper dentine. In lower incisors, certainly in the UK, we see a lot of young patients that have tongue and stud piercing, and we get fractures on lower incisor teeth, which is interesting. So look out for any patients who've got tongue studs or tongue piercings. They can cause localized fractures due to long chronic trauma, essentially. And age. So I'll talk about age because that has an effect on the dentine, the resilience of the dentine. And also the fact that the patient has been functioning for a lot longer. You're naturally going to get, we mentioned Craze Lines, but eventually those Craze Lines may penetrate deeper into deeper fractures. So these are all causes of fractures which penetrate into the dentine beyond the enamel. In terms of the prevalence, the lower 7s and lower 6s, lower first and second molars are the most affected. And the reason for that is they're the closest to the TMD. It's the fulcrum effect, or the nutcracker effect. So the closer the tooth is towards the pivot of the of the jaw, they have to withstand a lot more force, and naturally they tend to fracture the most often, followed by upper sixes, upper first molars, and also upper premolar teeth as well. So in that order, these are the teeth that are most affected by tooth fracture. So from fractures, what's the next stage? Well, the worst case scenario is the tooth actually splits right down the middle, and these teeth are pretty much hopeless. We can see this clinically. Usually the fragments might be mobile. The patients will feel at this stage that the pulp is usually necrotic, and what they will feel is tenderness on actually biting, because what happens when they bite, the food wedges the two fragments apart, and they're getting periodontal sensation now when you've got a fracture down the center of a tooth, or deeper than that. And then you take the amalgam, the restoration out, or in fact just get a probe. You can just tweak the fracture and the whole tooth separates. So this is quite straightforward diagnosis on this, and the unfortunate prognosis for these teeth is hopeless when the tooth splits. I'm not going to talk about root fractures in this stage. It's a completely different topic, but just to be aware, root fractures can occur from apical up to the coronal aspect for various reasons, trauma or obturation forces or other things, but they're rare, but they can occur. So at this stage, the take-home message is careful clinical examination. Once you've got the patient's symptomology, special tests, including radiographs and including your magnification to visualize the tooth structure itself. Don't forget to look at occlusal contacts, particularly if restorations have been provided in the tooth itself or the opposing dentition, both in static and excursive contacts. Any interferences will also cause occlusal trauma. Don't forget to look at the periodontal status of that particular tooth that's affected, and transillumination. So these are the critical things that you need to utilize at the initial stages in the terms of diagnosis. Now, let's look at the actual effect of occlusal trauma on the tooth itself. Now, in the majority of cases, teeth that are affected by occlusal trauma, the periodontal ligament is very resilient, is very good at withstanding and absorbing the forces, repeated forces, jiggling forces, but also long-term forces, or even impact, masticatory accidents, for example. The periodontal ligament is designed to absorb those forces up to a point. And if it's been a long-term or a chronic occlusal trauma, what you'll often get is, on the radiograph, you'll see widening of the periodontal ligament. This also applies, for example, with orthodontic forces as well. So that's a very subtle change you can pick up from a periapical radiograph. Just look for widening along the whole length of the periodontal ligament. But at a certain point, if the force exceeds the limit of the periodontal mechanism, then this is when the tooth structure itself will come into play and will have to withstand and absorb the force, and this is where things can sometimes go wrong. So we all know about the anatomy, the enamel, the coronal enamel structure. It's the hardest substance in nature, and in majority of cases it's designed to withstand the occlusion, articulation and function. And the anatomy, what I mentioned before, the natural anatomy of the tooth, the way the teeth interdigitate, they're designed in a certain way. The cuspal inclines, the cuspal pits, the cuspal slopes, they're designed to interdigitate with the opposing dentition. But when things change, teeth are moved, or when they're restored, that can sometimes change. And that's when we can start imparting forces onto the enamel, and the enamel will sometimes not be able to take it. Now, if we think about the enamel in a very simplistic form, almost like a cap. So when we apply forces onto the cusp of a tip, there's this concept of the compression dome, almost like a dome over a cathedral or a mosque, in fact. So when if you apply forces on the top of the cusp, the forces are distributed along and down the enamel in different ways. So at the top, the point of impact, or the point of direct occlusal contact, you tend to get compressive forces. Okay, but as you go down the axial wall of the coronal enamel, the forces change to more tensile and lateral forces, and that's where things start happening. Okay, this is when a fracture starts developing. Okay. Now, on top of that, obviously, enamel is not on its own. It's not a hollow dome. Within that, there is dentine beneath that, and that's a more of a viscoelastic substance. It's got higher collagen content and higher water content. So some of the forces will go through the EDJ and they'll be absorbed by the dentine. Again, this is nature's way of absorbing occlusal forces. Okay, and going back to our anatomy, basic anatomy, remember the tubular structure, where the tubules are in an S shape. Down to the pulpal aspect, and this in itself can also affect how forces are distributed and how fractures, if they do develop in the, for example, in the enamel, how they are absorbed at the EDJ, and the quality of the dentine or the property of the dentine will affect how quickly the fracture will penetrate and travel within the dentine structure, which I'll talk about in a second, including the amount of the hydroxyapatite content. For example, with age, the higher the content, the calcific content, the more brittle the dentine becomes, which is an issue with age. So the dentine in a younger patient is far more resilient to fracturing compared to an older dentition. So that's something to bear in mind, the actual tooth structure. Also to remember that in the crown of the tooth, the tubular structure tends to be more oblique or more vertical, whereas in the root, the tubules are more horizontal. And this may explain why the pattern of fractures, cuspal fractures, for example. So for example, in a classic class 2 or class 3 cavity, or MOD or a MO or DO cavity, if occlusal forces are applied on to a cusp, on this particular cusp, for example, you tend to get a compressive force, which is not an issue. It's on this particular cusp where there's a tension, where there's a tensile force, and that's where you see fractures. But also because the root dentine is more horizontal, the tubular structure is more horizontal, you tend to get more of a horizontal fracture, whereas on the coronal aspect, you get a more of a vertical fracture. And this is, for example, the case that I showed earlier where that mesiolingual cusp had broken off the lower molar tooth. This is the kind of pattern of fracture you tend to get in a vital tooth, where the cusp just breaks off. Okay. In terms of the dentine structure, so we've discussed the tubular densities. Now, we need to bear in mind that the density of the number of tubules in near the EDJ on the outer surface is far less than it is on the pulpal aspect, which means that fractures will travel faster the deeper they get into the pulpal aspect, because the tubular density increases on the pulpal side. So you need to remember that. So when fractures start penetrating into the dentine, we need to think about maybe protecting that tooth, because that fracture will penetrate faster and possibly more catastrophically the deeper or the longer it's left in the dentine. Tubular diameter is also important in terms of the amount of intratubular dentine that's laid down. This is an age-related thing. We know physiological changes in dentine increase with age in terms of calcification, and as I mentioned before, the older dentine is less resilient. It's far more brittle, simply because of the less water content and the increase in hydroxyapatite and lower collagen. So older teeth will fracture more easily. In addition to the fact that it may be restored, there are more brittle older teeth than younger teeth. So that's something to bear in mind in terms of deciding whether to restore a tooth indirectly or not. When we start introducing interferences because of our restorative procedures, this is quite a nice paper in the Journal of Prosthodontic Dentistry, where they looked at the effect on occlusal factors, and if there were any excursive interferences, any lateral interferences introduced into a tooth, then those teeth were 2 to 3 times more likely to fracture than a natural tooth. If you then add in parafunction, which we mentioned before, if you add in restorative procedures, size of cavity, those particular teeth could be 6 times more likely to fracture than compared to a sound unrestored tooth. So we need to bear this in mind, just to reiterate the fact that restorative procedures have an impact, particularly occlusal factors. So in terms of treatment, well, we've discussed about symptoms, post RCT symptoms. How do we treat those? Relieving the occlusion immediately post-operatively. But what about teeth that have deep fractures? How do we treat those? if the fracture penetrates deeply into the root dentine or down a root, do we take these teeth out? And this is what I was taught, and this is what most general dentists understand, that if you get a fracture within the pulp chamber, you have to take these teeth out because prognosis is poor. But is it? I think we're changing our approach to these, because there may be a situation where we can potentially treat these teeth, and using the design of our restorations, we could protect these teeth to give them a little bit more survival. So I've broken this down into various aspects. We'll look at, first of all, the coronal fractures, teeth fractures that are restricted just to the coronal enamel and dentine. Now, and this looks at the pulpal status. So if we've got a tooth that's got a coronal fracture into the dentine and the pulp status is normal, there's no symptoms at all, I think in those situations we could probably leave those. Now, in terms of just going back to the split tooth, we've decided that those teeth are pretty much unsavable, so we have to extract those teeth. But with teeth without symptoms, there's probably a case for just watching them and restoring them, because we're not really going to know if there are no symptoms of pulpitis. Those fractures could simply be Craze lines, and without penetrating into the dentine and doing any restorative procedures or access cavities, we're really not going to know whether the fracture is that deep. So those situations where we see these Craze lines, we're probably best just to keep and restore. Now, if going back to the social history, if there is known parafunction, and we've also checked the dental history, so if any restorations have been done opposing that tooth, we need to check the occlusion and adjust those, or provide an occlusal splint if there is a parafunctional habit, and that will hopefully keep the problem at bay, and we need to monitor those situations. So in teeth that have an absence of any pulpal signs but have fractures in the enamel, we can probably just watch those and deal with them at a local level. What about teeth that have a reversible pulpitis, the classic hot-cold sensitivity? How do we deal with these? Well, we know for sure that there must be a fracture within the dentine. And what does the evidence show us in these? And these are kind of classic studies that have shown that Krell and Rivera have shown in the first 6 months of teeth that presented initially with dentine enamel fractures and with a reversible pulpitis, a fifth of those, 20% of those, will devitalize, and those teeth, they've advised, should be crowned to try and protect those teeth from devitalizing. Another study by Paul Abbott and the workers in Australia, within 6 years, very similar outcomes. 21% of vital teeth that have enamel dentine fractures do eventually devitalize. So quite a consistent devitalization rate. So those two studies would suggest that we should crown teeth. Another study here, after 3 years, about 29% of those teeth that had enamel dentine fractures did become pulpally involved. So I think overall the message here is that around 3/4 of these teeth within 3 years will devitalize. So if you have a tooth, a patient that comes in with some symptoms of a reversible pulpitis, so short duration hot and cold sensitivity, and there is a visible fracture, I think those teeth, there is a case for protecting those with some form of indirect restoration. Not necessarily a full coverage crown, but some form of restoration to seal the dentine. Rakuchi showed some very, very nice work showing how pulps become affected, how the infection or the biofilm can penetrate into these teeth. So you have a fracture that's penetrated through the enamel into the EDJ, and if we look at the tubules, you can see the biofilm. First of all, you can see the effect, the inflammation within the pulp adjacent to the crack level, but also the penetration of biofilm within the dentine. So the biofilm will eventually penetrate from the crack through the dentine, and it will eventually affect the pulp. And as we said, about 20-25% of cases will devitalize because of this. So this is a reason to protect the fractures. Teeth that have, we see this a lot, these Craze lines over a period of time. Sometimes these Craze lines will penetrate deeper in, and you'll get maybe a chronic pulpal response. You get these pulp stones or long-term calcification, but eventually these teeth can devitalize, and you'll get biofilm within the pulp space. So this lower in size has become necrotic, and so sometimes if you get a tooth like this that has devitalized or discolored or starts developing symptoms, then those sort of teeth after the endodontic treatment we need to protect in some way. So that's the effect of a deeper fracture with it on the pulp. This is a case treated by a colleague of mine, a prosthodontic colleague of mine. This patient in the upper right 5 developed symptoms, thermal hypersensitivity, short duration, so reversible pulpitis, but you can see it's got an old amalgam restoration. There's fracture lines within the enamel in the marginal ridge here, and a very straightforward onlay preparation. So remove the amalgam, just make sure the fracture lines don't penetrate too deeply into the dentine. Because the pulp is still vital and it's not irreversibly damaged, we can preserve that without endodontic treatments. Very conservative preparation to flatten the enamel margins so we get a maximum bond, and apply a porcelain onlay. So it's a very conservative preparation and a very good way of treating these teeth that have got fractures, which could potentially travel further if they're not treated. And that's the kind of approach. And this is a kind of creating that compression dome that is mimicking the enamel that's been damaged because of the amalgam, because of cavitation. And that onlay preparation will hopefully hold the tooth together, as well as sealing the dentine, preventing the need for endodontic treatments in the foreseeable future. So I think teeth that have reversible pulpitis but deep fractures, I think those teeth, the evidence suggests that we should be protecting those with an onlay, at least an onlay preparation, if not a full coverage crown. And with the materials that we have, dentine bonded, and the ceramic materials that we've got, we can do that quite conservatively nowadays. In teeth that are reversibly damaged, well, these we need to root treat these teeth. We've got to deal with the endodontic situation, provided that the fractures line is not too deep. So in this particular case, we've got a fracture running right down the mesial marginal ridge of the 6. We see a lot of these, and this is another case where there's a mesial and a distal fracture. But the critical thing is the fracture lines don't penetrate into the pulp chamber floor. We can root treat those. What is root canal treatment itself? That doing the access cavity in itself will weaken the tooth, so we need to bear that in mind. And we have to be protecting the teeth that have had endodontic treatment and are extensively cavitated. A classic study by Reese shows that the effect of the cavity size on the tooth stiffness or the susceptibility of fracture. So if we look at an intact tooth at 100% integrity, an occlusal class 1 cavity, you only lose about 25%. But what is important, once you start losing a marginal ridge, whether it's a class 3 MOD, a class 2, sorry, or class 3 MOD, that's when the tooth integrity is significantly affected. And when you add an access cavity onto that, then we need to be protecting these teeth. Interestingly, an access cavity on its own, if the marginal ridges are intact, has very little effect. It only has a very similar to effect as a class 1 cavity, but it's losing the marginal ridges which are critical. Once we lose the marginal ridge, we need to be protecting that tooth either with an onlay restoration, otherwise the likelihood of fracture is increased significantly. Okay. So cavitation, access cavity to some extent. When we're doing our endodontic treatments, our radicular preparation, preserving the pericervical dentine is important. Okay, so our coronal flaring or reducing the coronal flaring, most of the instruments that we now use are quite conservative. We don't need to over-flare our preparations, particularly at the coronal end, and weaken the dentine there. A taper of the preparation, things are now becoming more conservative with narrower tapers, and potentially that would preserve root dentine, reducing susceptibility of fractures penetrating into the root. And also post design. We haven't got time to talk about the post, but this we know that, for example, parallel posts compared to tapered posts tend to induce fractures, vertical fractures more often because of their wedging effect. Threaded posts also increase the susceptibility to fracture because of the stress concentrations at the threads. So they're frowned upon now. So we don't use threaded posts if we can help it. And we're now using more dentine bonded fiber composite posts because of the bonding effect, and evidence at the moment suggests that they are comparable to traditional cast posts. The only difference is, of course, the mode of failure. So traditional metal cast posts tend to fail either by complete loss of the post or by root fracture, whereas dentine bonded and fiber posts tend to fail by fracture of the post rather than the root itself fracturing. But in terms of survival rates, 7 to 8 year survival rates for the fiber posts seem to be there at the moment. So fiber posts are probably the way to go because of the bonding effect and the fact that they seal well, and they could potentially hold a compromised root together. Moisture content, there is some evidence suggesting that root-filled teeth, because of the moisture content is reduced, they are slightly more brittle. Obviously, the access cavity itself has an impact, and also with time, collagen properties and the effect of irrigation, which is debatable whether EDTA combinations with sodium hypochlorite, they affect the corrosive effect of them, affect the dentine. Solvents, calcium hydroxide, some evidence suggests that long-term use of calcium hydroxide over 6 to 7 weeks has a negative effect on immature teeth. And calcium hydroxide obviously is what we used to use for apexification in young immature teeth. So maybe we shouldn't be using calcium hydroxide on a long-term basis, and we don't need to nowadays with MTA. We can avoid that. And also root-filled teeth do have less proprioception compared to a vital tooth. There is some effect of root filling a tooth on the proprioception and the jaw jerk reflex, as it were. Okay, and we mentioned the age, effect of age, in terms of the quality of the dentine, which changes with age. What about teeth that have fractures extending below the cervical level? Now, this is quite controversial because traditionally these sort of teeth we were extracting automatically because the prognosis was deemed to be poor. But recent evidence suggests that maybe this may not be the situation. These are classic studies that looked at survival rates of teeth with radicular fractures, non-vital teeth with fractures. In 5 years, for example, we've got some reasonably high survival rates for teeth that have got fractures within the radicular root dentine level. The most recent study by Davis and Sheriff, between 2 and 4 years, showed very high survival rates for teeth, success rates as well in terms of periodontal and periodontal health. So in the first 2 years, 100% survival rate in teeth that have radicular fractures. And after 4 years, the number reduces, but still pretty high, about 90% after 4 years in teeth with radicular fractures that need root filling. So there is an opportunity here that maybe we shouldn't automatically extract these teeth. If we can offer our patients a 4 to 5 year survival rate of, say, 80%, we should maybe offer that to the patient and let them decide whether or not the tooth should be taken out. And I'll talk about in terms of treatment strategy later on in a second, but there is a potential here for trying to keep these teeth. We know from the Eastman studies that these teeth that root filled must be crowned because that increases the survival rate by 4 times. So if we've got an extensively cavitated tooth with a fracture, we have to crown these teeth as part of the treatment protocol. What about teeth that have fractures and have the a periodontal implication? We mentioned before, part of the examination, we need to be looking at the periodontal health of the tooth. And when we start seeing isolated pocketing, traditionally we resort to taking the tooth out because the prognosis is poor. Now, in these vertical fractures, obviously, these are unsavable. But what about this situation where you've got an isolated pocket and where maybe the pocket up to 5 to 7 millimeters may not be terminal? When we look at those studies again and look specifically at the cases where there was periodontal pocketing, success rates and survival rates are still pretty high, 85%, 88%, 82%. In Davis and Sheriff's work, with fractures and pocketing up to 4 millimeters, they had up to 93% survival in the first 4 years, which is still quite high. So that's a radicular fracture, root fill tooth with a periodontal pocket. If we look deeper at this, pocketing levels up to 6 millimeters, 75%. In Davis and Sharif's prospective study, up to 7 millimeter pockets, 83% survival rates. That's still very, very high. So there is a case also, if you have a tooth that has a deep fracture, we can visualize that up to, say, 5 to 7 millimeters within the root canal orifice. Could we keep these? Could we maintain these teeth for a little bit longer? And Davis and Sharif suggested that we could do that if we use modifying factors, mitigating factors. For example, once we've done the root canal treatment, recessing the gutta perca down to below the fracture level, using a bonding agent or a glass ionomer to seal the orifice, relieving the occlusion, making sure post-operatively the restoration is not in any contact, occlusal contact, and certainly not in any lateral excursive contact, asking the patient to be careful, eating on the tooth before they have the indirect restoration, and ensuring with our referring dentists, or if it's our patient, making sure we do protect the tooth with a full coverage crown or an onlay as soon as possible, and then reviewing these teeth. There's a case for maybe maintaining these teeth for a little bit longer, and a lot of this is down to communication. It's due to, in the UK, a lot of emphasis is on consent and informed consent. So if we can advise a patient their tooth is compromised, there is a deep fracture in the tooth, but if we follow this protocol, if we can restore the tooth, we can provide a crown on the tooth, and we keep a close eye on it, you may be able to get another 5 or 6 years out of this. And there's maybe a 1 in 5 chance that the tooth will be lost, but a 4 in 5 chance you'll keep it. I suspect a lot of patients would happily agree to save the tooth. If it was my tooth, I'd certainly try and save it based on those odds. So things are changing, our attitude towards deeply fractured teeth, with our restorative procedures that we've got, the restorative materials that we can use. We could potentially save teeth that would otherwise be extracted. A couple of examples just to finish off. So this is the case I showed you before, where there is a deep fracture, and this is a relatively straightforward endodontic procedure. And the first thing is to remove, after the endodontic treatment, we remove the cusps out of occlusal contact before we restore, or before we send it back to a referring dentist, and that's quite important. This is another case where there is a deep fracture going into the orifice. It's an upper 6. This is the mesiobuccal MB1 and 2 orifice. This tooth also had a distal fracture. This is a fracture in the distal aspect. So there was a mesial fracture and a distal fracture. We do the endodontic treatment. You can just see the fracture going into the orifice. We recess the gutta perca down by 3 or 4 millimeters below the fracture level. What I now do in these cases, I use Flowable Composite. This is a composite that I really like because it's got a very fine metal tip. It's in the UK and Europe, it's called SDR. I think internationally it's called Surefill, but you can apply the Flowable Composite. And it's not Flowable Composite in terms of the anterior aesthetic composite. It's been designed to be a dentine bulk replacement composite. So it's got the structural integrity of conventional composite, but it flows and it doesn't contract significantly on curing. So it's a really good core material, but because of the fine tip, you can flow it into the intricacies. I also flow it into the fracture, the distal fracture line, so it adapts beautifully over the fracture and hopefully seals it and bonds it well. And then on top of that, you can use conventional composite. And then the critical thing is reduce the cusps, flatten all the cusp tips until they return to the dentist. Excursions are completely free. There's no occlusal contact on the tooth. We overlay the cusps, so effectively doing a direct composite overlay just to protect the cusps until the patient can have the indirect restoration. And that should protect the tooth and hopefully save it for a little bit longer. Another case with a mesodistal fracture. going right across the coronal dentine. Tooth has become necrotic. The fracture lines either side don't go through the pulp chamber floor. Any fractures that do go through the pulp chamber floor, we do know the prognosis for those is quite poor, unfortunately. But the fact that it hasn't, there's a chance to save it. We do the endodontics as normal. And once the endodontics is performed, this had a provisional restoration of IRM, but we clear the occlusion completely. So the patient, between the time they leave my office and they go back to the general dentist for the final restoration, there's no risk. And also tell them not to bite anything too hard on that tooth until they see their own dentist for the final restoration. So, take-home message, just to finish off. Once we've done our endodontic treatments, we've decided that we're going to try and save the tooth. If possible, we need to make sure the occlusal contacts are light or remove all excursive contacts before the indirect restoration. When we're doing the endodontic treatment, we're going to perform minimally invasive endodontics. We're going to keep the access cavity as small as we can, that is practically possible. And we're going to use restorations such as composite, bulk fill composites to bond and seal fractures within the teeth. And then eventually ceramic restorations or veneer gold if it's a posterior tooth to protect the teeth in the longer term. We do need to, in terms of our decision-making ethics, we do need to, and also the valid consent, we need to discuss the options with our patients. As I've shown you, there is evidence suggesting that the survival rates for teeth that are fractured and require endodontic treatment is pretty good, at least in the first 4 to 5 years. And it's better for us to let the patients decide whether or not to proceed with taking the tooth out or saving it. Most patients will try and save the tooth if they can, because the option of an implant is always there down the line if all else fails. So we need to have this discussion with our patients rather than automatically extracting teeth, because there are problems with implants. Implants have their own problems, and we're beginning to know and learn that implant success and survival is not the same thing. There are disease processes, periimplantitis, perimucositis around implants, which can cause different issues. But if we can prolong the longevity and survival of teeth, the implant option is always there, and technology gets better and better. Implants will get better and better. So that's always an option there in the future. So just to finish off, when you planning your treatment and diagnosis, begin with the end in mind. Have an idea of how you're going to restore the tooth, because it's not just about the root canal treatment, it's about how you're going to restore the tooth, how you're going to prolong the life of the tooth, and have that idea in mind. And if you're not doing the restoration, if you're a specialist referring endodontist, communicate with your referring dentist and how they should restore the tooth. That's quite important. Thank you. I think I've overrun, Dr. Prashant, but hopefully that's a quick overview of tooth fractures and the endodontic link there. Thank you.
Thank you so much, sir. Well, thank you so much, sir, for enlightening us with your experience on the Resto-endo interface. It's indeed, it's a great learning for all of us, and especially I think now, I think everybody will understand that it's not only about the endodontic procedure. We need to evaluate tooth both as endodontic, restorative, and also we can say periodontal evaluation is another very important aspect that we need to look into it. And I believe that with the minimal access design now, as the new concept of dentistry is changing, like we need to conserve the structural dentine, and also we need to preserve the maximum dentine of the tooth structure, both at the coronal and the radicular aspect. I think both will going to change the entire concept of the resto-endo interface. And as per your clinical experience and your all the evidence-based the presentation, we have, sir, some questions for you. Can I take up? So there's a question that what is your take on the endo crowns that are nowadays being done a lot? So what is your take on the endo crowns?
I don't see the need for them. I don't see the It's an interesting one. I'm not sure I trust the bond between ceramic, resin, and tooth as much as I trust a composite core, because we know the bond between composite and, for example, a direct composite core and enamel indenting. We know that works, and we apply layers. We use this new bulk fill composites. We can maximize predictability. I'm not sure about using a unit ceramic material and relying on the bond at a deep level, I'm just not, and also retrievability. If something goes wrong, you're never going to know until it's too late because of
Right.
recurring caries. Whereas at least with the composite, there's minimal contraction, there's no issues like that. So it's a nice idea. It makes things simpler. A single impression, a unit restoration is made, and you just stick it in. But long term, I'm not convinced. Not convinced personally. I'd rather do a composite core or a composite overlay and then prepare that and do a separate ceramic restoration or metal on top. That's my preference.
So there's another question about how is the air abrasion that we take as a sandblasting technique will it going to enhance our the endo-resto interface against the fracture, the sandblasting, if it is being done?
It'll certainly improve the dentine bond. Yeah. So if you have got a sandblasting machine, before, as part of when you're treating the dentine, removing the pellicle and all that, it will improve. It'll get rid of all the residual sealer material and GP and all that sort of thing. But also, there is evidence suggesting it increases the bond strength, definitely. So if you have that, it makes a difference. Yeah.
So we have another question about the post and the resin interface. The maximum fractures generally occur during the post and core. Generally, what we as a clinician observe when we do a lot of post and core for our patients. So a post and a resin interface, is there any clinical tip that you can give that with which we can actually enhance or we can actually make that bond much more stronger?
So this is for a fiber post, not a metal post.
Yes, for the fiber post. For the fiber post.
Well, first thing for me, when I'm as the endodontist, I will prefer to do the fiber post myself. I don't do the endodontics and send it back to the general dentist because I have isolation, I have orientation for the post preparation. With fiber post, one of the difference between fiber post and the old-fashioned metal is that it's very minimal dentine preparation or no preparation at all, because you're not relying on parallelism, you're not relying on size of the post, you're relying on bonding. So in itself is conservative. I would prefer to do the post preparation myself, which essentially is just taking the gutter perker down. I have pure isolation. I can see the etch or the bonding material go down the root canal because of the magnification. So in my opinion, it has to be the endodontist or the person who's done the endodontic treatment. They must prepare and place the post under magnification immediately after the root filling. Don't leave any time. The other thing is avoid using eugenol-based cements. Yes. I mean, nowadays there's resin or ceramics. So there's no real need to use eugenol anymore, I don't think, because the other cements are better. So there's no eugenol, and eugenol has some effect on bonding. We know that. So in my opinion, the endodontist or the person doing the endodontic treatment, they're the people that should fit the post.
Right. So there's another question that how we can improve the adhesion with the endodontically treated teeth. There is one question which has been asked. Is what are the different ways that we can actually increase the adhesion with the endodontically treated teeth? That is what we have.
I think some of that we mentioned before about sandblast. If you have a sandblaster, but it's making sure the etch goes into the root. So for me, I tend to recess the gutter perker down a couple of millimeters, even if there's not a fracture. I will still go down a little bit. I know exactly where the etch is going. You don't need to etch the dentine in root fill teeth as long. It's only 10-second etch maximum, not like enamel etching, which is maybe 30 seconds, 15 to 30 seconds. So less etching and making sure the bond goes all the way down and covers the entire surface. With magnification, you need to make sure it doesn't pull. You must agitate it to you need to enhance the hybrid layer. The dentine bond is always the weak link. It's never as strong as enamel. This is the problem we've got. But as long as there's good coverage of the resin, good coverage of the etch, and using the newer bulk fill composites, which are great, there's minimal shrinkage, and you don't need to do the layers as we used to do layering. You can do the bulk fill in 4mm layers, and then you use your conventional composite on top. It's made things more predictable, I think. A lot more easier for endodontists to do the core. So I do the core fillings myself, and before I used to send it back to the general dentist. So we can do it, and it doesn't take long.
So there's another very interesting question that which is more important, sir, the coronal dentine or the radicular dentine in terms of the resto-endo interface? Like that is like most of the time we talk about Coke bottle appearance Like that's one terminology which comes up. So what is yours, sir, your opinion on
Well, in terms of dentine bonding, the coronal dentine, because the tubular, we mentioned the S shape, and the bond is better in coronal dentine than it is in radicular dentine. This is one of the weaknesses of fiber posts. I think
Yes.
it's a lot more technique sensitive because the dentine down in the root is not the same. It's not the same quality. You've got to make sure there's no smear layer there. You've got to make sure you've got good penetration of etch, good penetration of resin, not like your resin. So you use dual cure to minimize the shrinkage and good flowing. So radicular dentine is never as good as coronal dentine. So you need to maximize radicular dentine, but also enamel. If there's enamel, enamel's where the best bond is.
Yes, that's it.
Always. So I would never rely just on radicular dentine bond. It's never good. The quality of dentine is never as good.
So it's like the question is, which one is better, sir, to go for, the total edge or the selective edge? What you recommend in terms of?
From what I understand, the evidence, there's no difference. I do total etch. I do total etch. But as I said, the etch must only be with the dentine on radicular dentine only for 10 to 15 seconds maximum. Otherwise, you'll end up destroying the hybrid layer.
Yeah.
So it's not. So in that way, I suppose you could do the enamel first, and then you go down into the depth of the dentine, because you don't want the etch to be for less time in the depth of the cavity. So yeah, it's select. But no, I'm not tempted to do. I do it in that order. It's total etch, but I do enamel and go down. And by the time I've injected down to the depth of the cavity, the enamel's had 30 seconds, and I wash superficially, then I wash into the cavity. So it's kind of total edge.
Yeah. Well, I think these are the questions we have, and I think you have already shared your email ID, so people have some questions, so they can send you on that.
Yeah, sure.
For this thing. And once again, sir, thank you so much. It's indeed a pleasure and honor for all of us. And on the behalf of the Global Summit, as the chairman of the International Cooperation Committee, I thank you for your valuable time and sharing your expertise, your knowledge, and the best what you as a clinician to our August gathering throughout the world. And we wish you a happy Sunday and stay safe and stay blessed. Thank you so much.
Have a good night, everybody.
Good night, sir. Bye bye. Thank you.
Bye bye.